All right, welcome back to the deep dive. Today, we're getting into something really key for MSRA revision, shingles.
Yep, shingles. It causes that, well, often very painful rash.
Exactly. And we're aiming for a high-yield overview here, really focusing on the core stuff you need based on the revision material.
That's the plan. Conditions like this, you really need a clear, structured understanding for the exam. We'll try and unpack the essentials quickly.
Okay, let's dive in then. This condition, shingles. What actually is it, like fundamentally?
Okay, so shingles is a viral infection. The virus involved is the Varicella-Zoster virus.
VZV.
VZV. Wait, isn't that the chickenpox virus?
That's it, exactly. And that's probably the most crucial starting point. Shingles isn't catching a new virus.
Right.
It's a reactivation. That VZV from when you had chickenpox, maybe years ago, it doesn't actually leave your body.
Okay. So it just hangs around.
Yeah, it goes dormant, sort of hides out in your nerve cells. We're talking the sensory nerve ganglia specifically.
And then, well, later in life sometimes, it wakes up again. That reactivation is shingles.
Got it. Reactivation of the old chickenpox virus. So that leads us to etiology. Why? Why does it wake up?
Yeah, good question. Like we said, it's the VZV reactivating from that dormant state in the sensory nerves.
What triggers it?
Well, the honest answer is we don't fully understand the exact trigger in every case, but the source material points to some pretty clear factors. Generally, it seems linked to a dip in your immunity to the virus.
Okay, so if the immune system isn't keeping it in check, which brings us to risk factors. Who's most likely to get this reactivation?
Number one factor is definitely age. Getting older, especially being over 50, significantly increases the risk.
Makes sense.
And obviously, you have to have had chickenpox in the past. No chickenpox history, no shingles.
Right, prerequisite. What else?
A weakened immune system is a really big one.
Like someone with HIV, for example.
Exactly. The source actually highlights HIV says shingles is about 15 times more common, but also other things that suppress immunity.
Such as?
Think about medications like long-term steroids or chemotherapy. Certain conditions, too, like Hodgkin's lymphoma, or people who've had bone marrow transplants.
Okay.
And interestingly, high levels of stress are also mentioned as a potential trigger.
That's a really useful list for revision. And, it makes sense clinically. The source mentions if you see someone, maybe younger, with really severe shingles, or it keeps coming back,
Yeah.
you should maybe think, could there be an underlying immunodeficiency that hasn't been diagnosed yet?
That's a really excellent clinical pearl to take away, definitely.
Okay, let's shift to the pathophysiology. How does this reactivation in the nerve actually cause that characteristic rash?
Right, so the VZV wakes up in those sensory nerve ganglia. From there, it basically travels. It moves down the nerve fiber, following that nerve's path, right out to the skin area that specific nerve supplies.
Like the nerve is a road and the virus drives down it to one specific patch of skin?
That's a perfect analogy, yeah. And because it sticks to that one nerve road, that single nerve root.
You get the dermatome pattern.
Exactly. The rash appears in that dermatome. This whole reactivation thing is often linked to a decrease in cell-mediated immunity, which brings us back to why age and immunosuppression are risks. The body's guard is slightly down.
Got it. And common places.
The source mentions the trunk is common, like dermatomes T1 down to L2.
Okay, that really explains that band-like rash, usually just on one side, which makes me think of a sort of exam-style question.
I'm for it.
Imagine a patient comes in, painful blisters, rash, but it covers the whole left side of their chest. Any wraps right around their back, clearly crossing the spine.
Okay.
Based purely on the pathophysiology, would you immediately jump to shingles?
And the answer, thinking about how it works, has to be probably not, right? Because shingles follows one dermatome. It characteristically does not cross the midline.
That's the key takeaway.
Definitely. Maybe a memory tip. Shingles sticks to its side. It never crosses the Great Divide.
Love it. Okay, so the rash pattern is often a big clue. But are there other things that could be? What about differential diagnoses?
Yeah, absolutely crucial. You've got to think broader. If you're looking just at the skin rash, could it be contact dermatitis? Maybe herpes simplex, which can look similar sometimes? Impetigo? Insect bites? Even atopic eczema or eczema herpeticum?
Okay, so other skin things. What about before the rash appears? That prodromal pain?
That's the tricky bit. That pain, depending on where it is, could mimic loads of things. Chest pain, maybe abdominal pain.
Right.
If it's on the head, could it be cluster headaches? Migraine? And if it's near the eye or forehead, you absolutely have to consider Ramsay-Hunt syndrome or other eye issues.
Good list to keep in mind. Let's talk epidemiology, the UK picture. How common is this?
Well, the source says incidence definitely goes up with age. Overall, about 1 in 4 people in the UK will get it at some point.
1 in 4, wow.
Yeah, and it's much more common in older adults. Highest rates are apparently in the 70 to 79 age group, but, I mean, it can affect anyone who's had chickenpox.
And that transmission thing. Can you actually catch chickenpox from someone with shingles? People get confused about that.
They really do. Okay, let's clarify. You cannot catch shingles from someone with shingles.
Right.
But the person with active shingles blisters can transmit the VZV virus itself.
How?
Through direct contact with the fluid in the blisters, maybe droplets too.
Yeah.
If they transmit it to someone who has never had chickenpox, that susceptible person won't get shingles. They'll get chickenpox.
Ah, okay. That's a super important distinction for advising patients. So shingles transmits VZV, causing chickenpox in the non-immune. Got it.
Yeah.
And vaccination.
Yep, there are shingles vaccines available, primarily aimed at older adults to boost their immunity and reduce their risk.
Makes sense.
The source also notes that chickenpox vaccine isn't routine on the NHS schedule, partly due to some complex population-level theories about how it might affect shingles rates in the short term.
Interesting. Okay, let's move to clinical features. What does it actually look like, feel like, stage by stage?
Okay, so typically, first you get the prodromal period. Usually lasts, say, 2 or 3 days before you see anything on the skin.
And that's the pain.
That's usually the main thing,
Okay.
yeah. Burning pain, often quite bad, in the area where the rash is going to appear, can even mess with sleep.
Anything else in that phase?
Sometimes, maybe about 20% of people feel generally unwell. Bit of a fever, headache, tired. They might notice itching or tingling paresthesia in that one dermatome, maybe some tenderness or swollen glands nearby, even before the spots come out.
Okay, then comes the main event, the eruptive phase.
Right. This starts as redness, maybe slightly raised erythematous or macular,
Right.
but it quickly turns vesicular.
Blisters.
Yep, clusters of small blisters. And again, the key thing visually, follows the nerve path, does not cross the midline. Those blisters keep popping up for maybe 5 to 7 days, then they dry out, crust over, and heal.
And it can be worse for some people.
Yeah, this source points out that in older people, or those who are immunocompromised, the rash might be more widespread, take longer to heal.
That midline rule seems really solid then. Once it's crusted over, is that it?
Not always, unfortunately. This is where the chronic phase or postherpetic neuralgia PHN comes in.
The long-term pain.
Exactly. Persistent nerve pain or pain that comes and goes
Ah.
in that same area. And it lasts for 30 days or more after the rash is healed or crusted. Can be really tough.
Nasty. Are there important variations like shingles in specific places?
Yes, definitely. Ophthalmic shingles is a big one. Affects maybe 10–20% of cases.
That's when it affects the eye.
Precisely.
Yeah.
Reactivation in the trigeminal nerve branch that supplies the forehead, scalp, and crucially, the eye.
And why is that one so flagged?
Because the risk to the eye is serious. It's considered a medical emergency. Needs immediate ophthalmology assessment.
What can happen?
All sorts, unfortunately. The source lists things like severe pain, inflammation inside the eye, uveitis, keratitis eyelid drooping, ingrown lashes, optic nerve issues, chronic inflammation, scarring, even permanent vision loss.
Wow. So symptoms.
Red eye, vision changes, light sensitivity, tenderness around the eye.
Okay. Message received. Rash near the eye. Immediate referral. Got it. Any others?
Ramsay-Hunt syndrome is mentioned too. That's when herpes zoster affects the facial nerve near the ear, can cause facial paralysis, ear pain, sometimes hearing loss or vertigo, linked, but a specific syndrome.
Okay. So ophthalmic is a really urgent one to spot. Now, investigations. Do we always need tests?
Often, no. Diagnosis is usually clinical, that classic story, that typical rash.
Yeah.
Usually enough.
So when do you test?
You test if it's not clear-cut, maybe the rash looks a bit weird, atypical, or if the patient is immunocompromised because their presentation might be unusual.
And what tests are used?
Well, PCR molecular testing is very good. Highly sensitive, reliable, pretty quick. Usually done on fluid from a blister.
Okay.
There's the older Zank smear, looking for giant cells in the blister fluid, but it's not as good as PCR. You can look for specific IgM antibodies in the blood during the acute phase. And for eye involvement, or if you suspect it's spread, they might use direct fluorescent antibody tests or PCR on, say, corneal fluid or blood.
And going back to that immunocompromised point.
Yes, if the presentation is really odd, super severe, keeps coming back, involves multiple dermatomes, the source emphasizes you absolutely need to think about and investigate for an underlying immune issue.
Right. Makes sense. Okay, let's talk management. How do we treat it? What are the goals?
Goals are pretty straightforward. Reduce the pain, speed up the healing of the rash, and crucially, prevent complications, especially that postherpetic neuralgia.
And the main tools.
Antivirals are key. Medicines like acyclovir, valacyclovir, famciclovir.
When should they be started?
Ideally as early as possible. The source really stresses starting within 72 hours of the rash appearing.
Is that for everyone?
It's particularly recommended for certain groups. Anyone immunocompromised, older adults, say over 50, people with severe pain, or if the shingles affects areas other than the trunk or limbs, especially the eye. For younger, healthy people with mild trunk shingles, the benefit after 72 hours is less clear, but it's often still considered, especially if pain is significant. Immunocompromised or older folks might need longer courses or higher doses too.
Okay, 72 hours is the magic window, especially for higher risk groups. What about pain relief? Analgesia.
Absolutely vital. Start simple, paracetamol, NSAIDs if appropriate.
And if that's not enough?
Then you escalate. The source mentions neuropathic pain agents like amitriptyline, gabapentin, pregabalin, duloxetine. These are often used for nerve pain. Topical lidocaine patches can also be really helpful, both acutely and for PHN.
What about steroids?
Oral corticosteroids are sometimes considered, mainly for severe acute pain in immunocompetent adults, usually within the first couple of weeks. But it's not routine. Needs careful thought.
Got it. And when do we need to get specialists involved? Referral.
Okay, critical points here. Immediate referral or urgent advice if there's any suspicion of eye involvement, ophthalmic shingles.
Right.
Immediate referral also for anyone who is immunocompromised. Their disease can be much worse.
Okay.
Urgent referral if there are signs of serious complications like meningitis or encephalitis. Specialist advice for pregnant women is also recommended. And for that persistent nerve pain, PHN, an early referral to a pain clinic is often a good idea.
Great summary. And patient advice.
Yeah, remind them about infectivity. While the blisters are active, they can transmit VZV to people who haven't had chickenpox. So avoid close contact with pregnant women who aren't immune, newborns, and immunosuppressed individuals until all the lesions have fully crusted over. Keep the rash covered if possible.
Okay, quick scenario then, testing that management timing. 65-year-old, generally healthy, shingles rash on their back, calls you, but rash started 4 days ago. Do you start acyclovir?
Okay. 65 years old puts them in the slightly higher risk group due to age. It's past the ideal 72-hour window. But given the age and potential benefit in reducing PHN duration severity, many guidelines would still support considering antivirals, although the benefit is less certain than within 72 hours. It's a judgment call, weighing risks and benefits, not as clear-cut as within 72 hours for this group.
Good point. Highlights the nuance. So treatment done. What's the typical prognosis?
For most people, pretty good. It usually resolves in, say, 2 to 4 weeks. The rash heals, maybe leave some slight skin color changes, but often no major scarring.
PHN.
That's the big caveat, isn't it? Postherpetic neuralgia can linger for months, sometimes even years. But starting those antivirals promptly does reduce the risk of developing it or its severity.
So prognosis depends a bit on age and health.
Definitely. Younger, healthier people tend to do very well. Older patients, immunocompromised individuals, pregnant women, they face a higher risk of complications. Actual mortality is very rare, though, mainly seen in severely immunocompromised patients with disseminated disease.
And prevention. We touched on vaccination.
Yeah, the shingles vaccine, like Shingrix, is recommended for older adults to boost their immunity against VZV reactivation.
Okay, last section then. Complications. Let's just run through the main ones again, besides PHN.
Right. PHN is the most common, affecting, maybe 5–30%, much more likely if you're older.
Eye problems.
Huge issue in ophthalmic shingles. Pain, inflammation like uveitis, keratitis, scarring, vision loss, really serious.
Ramsay Hunt.
Yep. Facial paralysis, ear issues,
Skin.
scarring, pigmentation changes are possible.
Yeah.
Secondary bacterial infection of the blisters can happen too.
Neurological. Rarer stuff.
Yeah, things like Bell's palsy, meningitis, encephalitis, myelitis, spinal cord inflammation, even hemiparesis or stroke in some cases.
And in the immunocompromised.
The big worry there is disseminated zoster, the virus spreading widely, can cause pneumonia, hepatitis, encephalitis,
Yeah.
much more dangerous.
That's quite a list. Really brings home why it's important.
Absolutely. It's definitely not just a rash.
So wrapping up, thinking about this for revision, shingles, it's more than just skin deep, isn't it? It's a story about latent viruses, immunity, nerve pathways, and the potential for quite significant complications, from long-term pain to sight-threatening emergencies, really highlights why spotting it, especially in those vulnerable groups, and managing it properly is so crucial.
Well said. Understanding the pathway, the risks, the red flags, that's a key.
And that was our deep dive into shingles. Hopefully that's given you a clear, high-yield framework for your MSRA revision, drawing on those key source materials. For more free MSRA revision resources, remember to check out freemsra.com, and the full premium revision toolkit is over at passthemsra.com.
Yeah, best of luck with all your studies.